Hi, my name is Dan Mangrew, and I'm from the Advanced Stem Cell Education Program, as well as the South Florida Bone Marrow Stem Cell Transplant Institute. Today, we're in for a really great presentation. Our presenter today is Dr. Dipnarine Maharaj. Dr. Maharaj has long been one of the pioneers of stem cell transplantation, going back to his days in Scotland with the original group that pioneered stem cell transplantation for leukemia patients, and then going to found the bone marrow stem cell transplant program at the University of Miami, and now into his current practice where he's able to innovate new treatments for patients, as well as having established the Advanced Stem Cell Education Program, which is a CME education program for physicians. As far as for today's webinar, Dr. Maharaj will be giving his presentation, and then we'll be answering questions at the end. So we do advise, encourage everybody to feel free to send their questions via our chat feature on today's webinar, and we look forward to having a great presentation. And without any further ado, we'd like to introduce Dr. Maharaj.
Good afternoon, ladies and gentlemen. It's a pleasure to be here speaking to you, and thank you to all our guests who are listening and have taken time from their busy schedules to be with us today. As Dan has mentioned, this is an area that I've been involved in for over 30 years, more than 30 years, as a stem cell transplant physician. And what I would like to do is basically go over some of the areas that I feel that are important for anyone involved in stem cells or learning about stem cells. It's also one of the reasons why I established the Advanced Stem Cell Education Program and developed a curriculum that covers the sciences of stem cell, from basic science to translational research, as well as to current practice. Now, the field of stem cells are evolving continuously, and also as a result of that, there are issues that could arise from a regulatory point of view. So in today's lecture, I'm also going to discuss some of the more recent changes and give you my opinion as to how I feel about these changes that are taking place with the development of new types of treatments for stem cells. So without further ado, I'd like to move on to my next slide. And today what we would like to cover is what exactly is a stem cell, where do they come from, how do they work, how are researchers and clinicians using stem cells to treat diseases, and how can stem cells help scientists better understand diseases. As mentioned before, this is an area that I've developed expertise in for more than 30 years. My background is I'm a hematologist oncologist with specific training in stem cell transplantation. I'm the course director of the Advanced Stem Cell Education Program, and we have ongoing clinical studies that are part of our program. I'm the medical director of the South Florida Bone Marrow Stem Cell Transplant Institute. We are a global leader in regenerative medicine. Our focus is on using the individual's own stem cells, and we've developed protocols that covers the whole family. Some of the services that we are providing include cord blood banking. We are private cord blood banking. For young adults, we are looking at ways to be able to measure, preserve, and store the immune system by collecting the individual's own stem cells. For chronic diseases, we are diagnosing and treating the root causes of immune dysfunction. And I'll discuss that in more detail in the third part of my presentation. For blood cancers and immune disorders, bone marrow stem cell transplantation is an established indication. We have protocols under study for solid tumor patients with immunotherapy, and then, of course, our educational program and our ongoing research. Now, many people might think that stem cells were developed in the late 90s, but in fact, the first, in 1961, the first group to identify the unequivocal existence of a stem cell was an Australian group, and they basically identified the hemopoietic stem cell. Subsequently, treatments developed, and in fact, in the early 80s, we in Scotland were one of the first groups to be able to utilize an individual's own stem cells to treat patients with leukemia. And there were many other transplant centers around the world that were being developed to be able to use hemopoietic stem cells as a source of treatment for blood cancers and immune disorders. However, there was a game changer around in the late 90s when two scientists, one was Thompson, the other was Gerhardt, they isolated stem cells from human embryos. And because of the potential of these embryonic stem cells, everyone thought that this would be the future of stem cell work. The problems that arose were predominantly ethical and moral issues, and many people were against the idea of using embryonic stem cells derived from human embryos. A very distinguished professor in Japan named Yamanaka in 2006 actually was able to identify a different type of stem cell called an induced pluripotent stem cell, which the idea was that it would solve many of the ethical issues raised by the use of human embryonic stem cells taken from an embryo. So I think the next question one has to ask is, what exactly is a stem cell? A stem cell is essentially a cell that that has two capabilities. Number one is that, as this slide shows, it can actually undergo self-renewal. So that is, it actually renews itself. But the second aspect of a stem cell is that it can differentiate to form into different types of tissues. And so those are the two characteristics which differentiates a stem cell from another type of cell in the body. So what is an adult stem cell as distinct from an embryonic stem cell? An adult stem cells are found among specialized cells in every tissue or organ of the body. They can renew or differentiate to yield the cell types of the tissue or organ where found. So for example, in the brain, there are brain stem cells which are found in the hippocampus, and these play an important role in memory and emotion. There are stem cells in the heart, there are stem cells in the kidney. And another term that's often used for these adult stem cells is that they are often called somatic stem cells. So this slide shows essentially some characteristics of stem cells. First of all, that they are responsible for homeostasis and repair in the human body. Each organ of the body, as I said before, contains stem cells. So if you look at this slide, basically cells within the blood or the gut or the skin or other tissues outlined here in green, they have a high cellular turnover, high regenerative potential, and huge numbers of stem cells. Whereas on the other side in red, you see lung, brain, heart, retina, kidney, and spinal cord. The numbers of stem cells in each of these organs is actually very low, and the regenerative potential and the cellular turnover is actually very low. So it would make perfect sense to say that could stem cells from, let's say, the blood or the bone marrow be used to repair the stem cells in these different organs where the regenerative potential or repair potential as well as the numbers of stem cells are low. And this is where the future of regenerative medicine has been turning to, and we will discuss that in a little bit more detail. So as outlined in the previous cell, every organ has its own stem cells. The bone marrow is one of the organs with the most abundant source of stem cells. And if you remember from my first slide, Till and McCulloch were one of the first groups that were able to identify an adult stem cell called a hemopoietic stem cell, and that came from the bone marrow. So this, in essence, is the type of stem cells that we have the most experience with. These bone marrow stem cells originate in the bone marrow, circulate through our blood, and they're there because they're present in huge numbers to naturally repair tissue or an organ damage. So for example, if somebody has a stroke and you measure the circulating levels of stem cells in their blood in the week after the stroke, you will actually find that the number of stem cells coming from the bone marrow is high, because those stem cells are being drawn out of the bone marrow to go towards the brain to help to repair that damaged area. Another characteristic of the fact that these cells are in the bone marrow is we've learned a lot that these cells could be safely collected. And say, for example, a newborn, where in the placenta or the afterbirth, that's the blood that's contained there contains huge numbers of stem cells, and these can be collected and stored for the child for a later date if they should ever need a stem cell transplant. Not only can they be collected at the time of birth, but also they can be collected from anyone at any age. Of course, as we age, the numbers of stem cells that we have available to be collected, which come from the bone marrow, decreases. This process is called mobilization, and annually 20,000 healthy individuals have their stem cells mobilized from their bone marrow into the blood, and they take these cells and they donate it to someone who has a life-threatening condition like a blood cancer or an immune disorder. This slide shows essentially what that process of the stem cells residing in the bone. You see here a picture of a bone. It's a femur, and within the bone marrow of the femur and the large bones, as well as the axial skeleton and the ribs, there are large numbers of stem cells in there sitting in it's almost like in a reserve tank. When the cells of the blood or the immune system are required each year, one of what we call a pluripotent, that is a stem cell that's sitting in the bone marrow, can be released, and it regenerates the bone marrow and the immune system every year. Now, some of these stem cells can also be released on an ongoing basis, on a daily basis, and they circulate to other organs where there's damage, and they help the repair process as well. Now, so far I've been talking about adult stem cells, and that's the area that, again, had the developmental work started in 1961, and the use of stem cells for transplants of blood and immune disorders was essentially a sort of a standard of care, standard practice. However, in 1998, on the scene arose the idea of using human embryonic stem cells. And what are these? These are derived from fertilized eggs. Most come from eggs fertilized outside the body, for example, in vitro fertilization, and from clinics that are involved in vitro fertilization. And the leftover fertilized eggs are often donated for research with informed consent. A characteristic of an embryonic stem cell is that it can become any cell type in the body. And this was often the reason, this was one of the main reasons why, with the discovery of this type of cell and the ability to grow it in culture outside of the body, was heralded as the future of medicine. This next slide shows, essentially, it's a picture which shows on the left-hand side, you see a single embryo, and at 3 days and then 5 days. And at 5 days, these are the stems, to produce embryonic stem cells, the cells are taken from this area that we call the inner cell mass. If the embryo continues to grow, then you have essentially a child and then an adult. But the cells that were used that Gerhardt and Thompson identify were taken from a 5 to 7 day embryo from an area of the developing embryo called the inner cell mass. And these cells were then taken, and this method was patented by the University of Wisconsin. The cells were taken from the inner cell mass, they were plated in culture dishes, and then they were allowed to grow. And the idea was that they could proliferate indefinitely and form any tissue. This is a picture of what these cells look like when they're growing in a culture dish. And however, after a lot of publicity and discussion and debate for the use of embryonic stem cells, it was later on found that there were some problems, and these continue to be problems that have nagged the field of development of a pharmaceutical type of stem cell called an embryonic stem cell. And first of all, one of the difficulties is that when you take these cells and you put them in culture, it's very difficult. It's often difficult to establish and maintain them in culture so they can then grow to be involved in large-scale production. It's difficult to obtain pure cultures of these cells in growth. The potential for mutations is high. Because they're embryonic stem cells, they have the potential to form tumor. There's often difficulty in triggering them to undergo differentiation to form functional tissues. There's also the problem that when they mature, that they represent the immune system of the donor. And if that is to be put into a recipient, then there's a problem of immune rejection. As the cells are growing in culture, they develop mutations within the DNA, and it's very difficult to control for that. So that's called genomic instability. And there have been few clinical treatments so far, in spite of the extensive funding and research that has gone into the use and the development of embryonic stem cells. And of course, they're ethically contentious, whether the use of taking stem cells from an embryo. So, as I mentioned earlier, in the terms of historical development of stem cells, the Japanese scientist Yamanaka, what he did was he basically found that if you isolated cells from the skin or fibrous tissue of an individual, this is a grown individual, and then you treat these cells with what's called reprogramming factors. Many of them involve using viruses. And then you wait for a few weeks, then what you have is that the differentiated cell, for example, from a skin, can actually be differentiated to an embryonic stem cell, like called a pluripotent stem cell, and that these cells can then often be triggered to go on to differentiate tissue like the heart, gut, or blood cells. And so that means that this could represent a new form of development. And there are many research organizations, universities, stem cell programs that are now currently and very actively involved in the use in research to identify ways that these cells could become a product that could be used for regenerative medicine. However, there are also roadblocks with the use of these induced pluripotent stem cells. And these, for example, the requirement for virus vectors or the products of viral vectors, these so-called Yamanaka factors, which can allow the cell to be reprogrammed. Also, the mechanisms of reprogramming of how you allow a differentiated cell like a skin cell to be reprogrammed to become an embryonic stem cell or a pluripotent stem cell. There are difficulties with the quality control of the reprogramming and the functional implications of the types of tissues that are produced, and whether they are the most appropriate sources for cells, and what are the most appropriate sources for cells. Is it skin or another organism? So another issue, of course, is that the age of the individual in whom you're taking the cell to be reprogrammed. Often these cells may have mutations because of the aging, and mutations occurring in the individuals as a result of exposure to environmental toxins. So these are all issues which could affect the quality of the product that's produced by an induced pluripotent stem cell. So really, for clinical use, again, going back to our experience starting in the 70s, 80s, and going forward, the traditional type of stem cells that have been used are adult stem cells collected for clinical use from bone marrow, peripheral blood, cord blood, and more recently from placenta. there's most of the work involving or clinical work involving embryonic stem cells or induced pluripotent stem cells are still under studies by companies that have filed investigational new drug applications with the FDA, and so they're still very much in early phases of clinical research. In Japan, there are many companies that have invested in the use of induced pluripotent stem cells to determine whether this could be a product for the future, and those studies are ongoing. But to date, there's no product using embryonic stem cell or induced pluripotent stem cells that have been proven to be a clinically useful product. Our work, I wanted to highlight some of my own experience and what we have learned from the use, our work in developing the use of adult stem cells derived from the bone marrow, which is now a standard of care. So I was involved in the early 80s at the University of Glasgow, and we were one of the first programs to use an individual's own stem cells to be able to treat patients who had blood cancers and immune disorders. Alternative sources would have been to use a donor, but because often finding the donors was a problem, we felt that an alternative route would be to be able to identify whether we could use the individual's own stem cells as a source of rescue after giving the patients high dosages of chemotherapy. In our first study, after an initial number of 12 patients were treated, and which was published in The Lancet in November 10, 1984, we demonstrated that for patients whose potential survival was less than 5%, that at 3 years, 58% of these patients were still alive and disease-free. And this represented a major advance in terms of how we could treat patients with leukemia. Our initial thoughts were that it was the high-dose chemotherapy which was responsible for killing all the leukemic cells within the bone marrow, and that the stem cells we put back, they were basically, because most of the leukemia had been eliminated, that the cells that put back would not have caused further leukemia. However, as we studied, and as I've studied over the many years, the transplant process and what we were actually doing, it became clear to me that if you look at patients, for example, who have multiple myeloma, non-Hodgkin's lymphoma, or leukemia, and you look to see, you can identify those patients who are going to do well versus those patients who will not have long-term survival. And one of the interesting factors is that you could predict early which patients are going to do well, and that's based upon looking at cells of the immune system, including the lymphocytes. And when we looked further at these patients, what these two graphs are showing is that they're showing overall survival of patients who received bone marrow stem cell transplants using hematopoietic stem cells. And if you look at particular cells within the immune system, these are called natural killer cells, you could see that the long-term survivors, or the people who are destined to do well, that their immune system is undergoing a recovery, and you can identify it by cells called natural killer cells, which are part of the innate immune system. So what was clear, I've learned over the years, is that it's the recovery of the immune system following a stem cell transplant which is critical to the survival of the patients who we are treating. Our work was initially a pilot study, but the next slide, which is a slide taken from the Center for the International Bone Marrow Transplant Registry, and was published in 2011, shows that now that this is a standard of care, and that the survival of patients with acute myeloid leukemia after an autologous transplant is essentially not far away, close to the 58% that we saw in the patients who we initially did the pilot study. So this is now a standard of care, and I'm very proud to be able to say we were part of some of the pioneering work that has now allowed the development of this standard of care type of treatment using an individual's own stem cells to recover the immune system of many patients with blood cancers like acute leukemia. So what this slide shows, and it's a very busy slide and I apologize for it, but many people feel that the use of stem cells is still very new and investigational. But what the purpose of showing you previously, the previous slide, that is that the use of stem cells, adult stem cells from the bone marrow, is a standard of care for not only for blood cancers, but also many other diseases. And there are over 80 diseases where which are clinically accepted as for the use of stem cells, adult stem cells. And so again, the source, bone marrow, and hematopoietic stem cells are the traditional uses that have been clinically accepted. Here's another group of blood disorders, immune disorders, metabolic disorders, and even solid tumor cancers, where it's accepted that the use of hematopoietic stem cells as a sort of stem cells, of adult stem cells, is a standard of care and practice. Now, in the next part of my talk, what I want to do is to talk about some of the more recent developments of where very innovative physicians have been exploring the use of different types of stem cells for regenerative medicine. And unlike hematopoietic stem cells or stem cells derived from the bone marrow, which is a standard of care, which we know the safety and it's proven, adipose-derived stem cells is relatively new. But many physicians are actually embracing it and incorporating it into their practices. And I believe that for our patients, we've got to be very careful about the use of adipose-derived stem cells, that it is still very new and we don't fully understand the potential side effects and the benefits of it. And so I want to show you my thinking about what fat is. Fat, this slide shows essentially a very healthy individual with the fat. And basically fat is really an immune organ. And if you look at the composition of fat, it has a structure which is clearly defined, but it also has cells within it. And in a very healthy individual who is in what we call an anti-inflammatory state, like this individual is, the cells of the immune system within the fat are producing factors which keeps the individual in an anti-inflammatory state. So however, in situations where there's excess accumulation of fat, like in this next slide, where the fat is actually now responding to toxins that are being accumulated in the individual, it actually changes to be the immune system of the fat actually changes so that it actually becomes an inflammatory type of tissue. It expands, the numbers of immune cells, of macrophages and lymphocytes increase, but those cells are actually producing inflammatory factors, which can be, which basically is driving inflammation and driving diseases. So for example, we know that if you look at obese individuals who have diabetes, the incidence of cancer is 15 times greater than an individual who who's not obese and who does not have diabetes. And so we have to, the question then is why? So if we're going to actually extract adipose fat from an individual and extract the stem cells from that, the question is, well, why would there be lots of stem cells within fat? And are there a particular type of stem cells, and why should those stem cells be in the fat? And the explanation that I would like to propose to you is that because the fat in individuals who've got excess amounts who are obese, it's an inflamed tissue, and the stem cells that are there are particular types of stem cells called mesenchymal stem cells, which have come from the bone marrow and are growing in abundance. So many physicians are basically extracting this tissue as a source of the stem cells that are there and using it for treatment of different types of diseases. My concern is that these cells, these mesenchymal stem cells, they have a characteristic which means that they are immunosuppressive. So therefore, using these cells plus the factors which are inflammatory factors and their capability of immune suppression in individuals means that we could be putting patients at risk without fully understanding the complexity of the organ that we're dealing with. So in addition to that, if you search the literature, you will see that there are some hazards associated with the use of mesenchymal stem cells. And in fact, this picture shows fat which has been extracted. There, at the bottom you see red cells, and this is what the fatty tissue looks like when it's been extracted from adipose tissue. But the mesenchymal stem cells within that, from that fatty tissue, which has been manipulated, which when it's extracted, manipulated, and can be re-injected into another area of the body, which in fact it was not intended for, could cause problems. And these fat cells used in this way may end up creating new bone cells instead of fatty tissue in the organ in which it was put in. And in fact, there is a publication which appeared in the New Scientist Scientific American in 2009, which showed that a woman who had experienced pain and clicking in her eyes after receiving a facelift that used her own mesenchymal stem cells, that when she was evaluated at surgery, it was found that these were due to pieces of bone which had arisen from the mesenchymal stem cells, which had differentiated into bone tissue. So therefore, mesenchymal stem cells release cytokines, which were also triggering the formation of bone. We also have to be concerned about mesenchymal stem cells taken from fatty tissue, because as I showed you before, in the fatty tissue is an organ which has an excess number of inflammatory cells of the immune system, and some of these cells include cytokines, which one of them is for example, tumor necrosis factor, which can actually stimulate tumor growth in previously dormant cancer cells. So we've also got to be careful about that potential risk as well. Because of these issues, there's recently been some further information provided by the FDA concerning the guidance, and this is in the form of a guidance document which the FDA has issued concerning the use of adipose-derived stem cells. Now, in the FDA, there are regulations which the Center for Biologic Evaluation and Research, which stands for CBER, as part of the FDA, they implement the regulation of two laws, which is the Food and Drug Cosmetic Act and the Public Health Services Act for biological products and stem cells. And there's also another regulation which specifically regulates human cells, tissues, and cellular and tissue-based products. And I'm not going to go into the details of these, but really just to highlight that what the FDA has created is a unified registration and listing system for establishments that manufacture these tissue-based products and stem cells, human cells, tissues, and cellular products, called HCTPs. Any program that's involved in the use of stem cells for what the FDA requires, they've got to undergo this unified registration and listing system for their establishment. The purpose of this is really for the safety of patients, and the idea is that specified within these regulations are the requirements for donor eligibility, good current tissue practices, procedures to prevent the introduction, transmission, and spread of communicable diseases. And this is a very important point when you're dealing with stem cells, because essentially you want to prevent the transmission of diseases from one individual to another if you're utilizing their stem cells. And even if it's the same individual, you have to be careful, because if the cells are extracted, they could be contaminated and could be then, when put back into the patient, cause severe infections or problems. So the stem cells under these regulations are classified under high risk, for which they're classified as drugs. There's an intermediate risk group, which, for example, hematopoietic stem cells and the use of stem cells for treating blood and immune disorders falls in. And these are classified as satisfying four requirements: minimally manipulated, homologous use, which is for the cell that's taken out is put back into the same cell of origin, and that the manufacture does not involve the manipulation and the addition of anything other than these specified agents here, And then also whether it's autologous or autologous, but if it is allogeneic, which is from a donor, that it's for use in a first degree or second degree blood relative. So there's also a classification which is low risk, which is accepted from compliance with Part 1271. And usually if anyone is involved with any new type of stem cells that are going to be used, then it is recommended by the FDA that they consult the FDA personnel with regards to determining how the tissue that they're going to be using is regulated. And there's a group as part of the FDA called the Tissue Reference Group, which basically gives information on to questions that are asked about the use of the clinical use of a particular type of cell. So examples, I'm going to give a few examples of the types of adipose tissue which have been asked and which the FDA in their guidance document have given information. So for example, someone asking, a physician saying, well, I take fat stem cells or adipose stem cells, we digest it, we process it, and we inject it back into patients who have urinary incontinence or treatment of impotence. The FDA, based upon the tissue reference group information, have said that this is a drug and needs to go through the IND process because it's not homologous use. Although it might be done in what's called the same surgical procedure, which potentially could have exempted it, but it's not. So the tissue reference group have basically said that this is a drug which needs to follow the drug development pathway. Similarly, the FDA has also made clear in their guidance document, which was recently issued, what it considers minimal manipulation, which is a key standard for regulatory compliance. And they've issued this particularly in reference to adipose tissue. When fat is actually extracted, if it undergoes any type of processing or manipulation, for example, enzymatic digestion, mechanical disruption, to isolate the cellular components, which is often called stromal vascular fraction, the FDA basically said that this is more than minimal manipulation, and therefore, if it is being used, then it has to be done as part of the regulatory process. That is to be submitted for use under an IND as a new drug development. Similarly, another question was made, again, for minimal manipulation. What about if you take the tissue from a deceased donor and you treat it with acid or detergent, you wash it, you decellularize it, and you ground it up to obtain a fibrous tissue suspension? That's regarded as more than minimal manipulation as well. What about if you have the question of homologous? Homologous meaning that if you take the cell from one area, you need to put it back into the same tissue. What they've said is that basically, if you take fat and it is not changed, and it is used to fill the same use that it was taken from one part of the body. So, for example, to use it as a cosmetic to fill voids in the subcutaneous space in fat or hands, that's considered homologous use, and therefore it does not require the regulatory process that is more stringent that needs to be undergone for the higher risk tissues. What about for adipose tissue, which is taken and used to treat bone and joint disease? This is regarded as a non-homologous use, therefore it needs to be treated under an IND. What about adipose tissue that's recovered and processed for injection into the breast for non-implant augmentation, often used for cosmetic reasons? Again, this is a non-homologous use, therefore it needs to be treated as a drug in terms of its drug development pathway. So essentially, the conclusion we can draw to is that there are established adult stem cells that can be used for clinical use. Our work has shown, and the work that's shown, that in fact the use of adult stem cells, which are accepted and for which is a standard of care, that really one of the most important ways that these adult stem cells or hematopoietic stem cells are working is to actually recover the immune system. So I'd like to share with you in the next the third part of my presentation, what I feel is the importance of that information and how it could be used in a way that could help us all to lead better lives. And in fact, the idea is that if we can utilize that information, we can also learn about our immune system, the role of inflammation, the immune system, and how stem cells play a role in the improvement of the immune system. There's a lot that we could do before the onset of diseases so that we could have healthy aging. Excuse me. And I want to share with you some of my own thoughts as to how we can do that. So this section is titled Personalized Immune Health Solutions. For all of us, our dream is healthy aging, a high quality of life into the late stages of our lifespan with few daily living impairments and a near absence of age-related disease. Unfortunately, the reality for most people is that it's an unhealthy aging trajectory associated with the onset of diseases, a diminished quality of life, increased risk of dying at a younger age from disease. And why is that? Because essentially we have a number of major problems. For example, obesity is one of the most common problems we face in the United States. The incidence of cancer amongst men, 1 in 2 men are likely to develop some type of cancer, 1 in 3 women. Smoking is still the types of diseases that we see, a tremendous amount of disease caused by toxins such as smoking and other environmental toxins. So what we really have for most people by the time they reach age 60 to 65 is a downward decline based upon the onset of most of these diseases. So the first question is, well, what could be the root cause? Well, this concept of inflammation is not new as a cause of disease. It was published actually in Time magazine in 2004 that in fact there's a very strong link as a root cause between inflammation, heart attacks, cancers, Alzheimer's, and other diseases. And in fact, it's my opinion, based upon my experience over the years of doing as a stem cell transplant physician and focusing on the immune system as to how we could recover it in patients who had cancer, that I feel that the immune system is our fundamental building block to our best health. And health is a balance of inflammation and the immune system. And in fact, when we think of our immune system, we often think we have to look at it at its basic core processes. We have 2 types of a functional immune system. We have the innate immune system and the adaptive immune system. And if we can, and as we measure this, we can actually identify where someone is in terms of the potential decline of the immune system, although in fact they may appear looking to be healthy. So we've been focusing on measuring these components of our patients within our program. And what has been very striking is where individuals who might think that they're healthy have major defects in their immune system. And I'm going to share with you some of the data as to the evidence for why we have to be concerned about whether, when our immune system begins to deteriorate, the potential for the diseases that are occurring later, which could affect where defects in our T cells or our B cells, our innate immune system, including our natural killer cells, are predicting that diseases are appearing later, could be appearing later. So if we look at our immune system and the factors that produce inflammation, which are basically our pro-inflammatory cytokines or mediators, they're balanced by anti-inflammatory mediators, and the immune system is the pivot, is really what keeps it into balance. As we age, our immune system deteriorates and inflammation increases, the potential for anti-inflammatory mediators to balance the inflammation is decreased, and so the extent of the disease process is determined by the severity of the inflammatory process. And this is shown in this slide, that inflammation is certainly part of aging, but severe inflammation is really the root cause of cancer, neurological diseases, metabolic diseases, bone diseases, skin problems, cardiovascular diseases, conditions such as chronic fatigue syndrome, chronic inflammatory diseases. So basically, if we can identify ways to reduce the inflammation which is occurring at an early age or during our aging process, we can and potentially would be able to forestall the incidence of these diseases. I'd like to sort of give you an example of how I feel this all fits together. This slide basically shows it's an example of a house. So if we imagine the human body is like a house, internally, if our inflammation is controlled, we look pristine, like the upper part of these slides in the house with the kitchen, the living room, and the bedroom. However, as the immune system begins to deteriorate, the control of the inflammation decreases. And so you go from the picture on the left where the fire is just beginning to burn to the middle room where the living room is burning down, and then eventually the kitchen where it's just a total wreck. In many patients, in the majority of patients, by the time symptoms occur and onset of diseases are occurring, they're the equivalent of the second and the third slide. So if we're going to make an impact in terms of preventing diseases or a move towards a change in the paradigm from disease to healthy, we've got to look at what is occurring in the first slide and looking at ways to be able to control that inflammation and maintain a healthy immune system. So our immune system is really essential to healthy longevity and cancer resistance. And the cells of our innate immune system, our natural killer cells, are designed to kill cancer cells, and they can predict cancer resistance and overall longevity. And we can measure this. This is actually an assay which can be done on a blood test where you can measure the cancer killing activity of an individual's cells. And this slide shows in green cells that look like lymphocytes, in black the cancer cells, and then as the cancer cells are approached by the natural killer cells, they expand, and the natural killer cells actually, if you look, they almost have sort of fingers where they're grabbing the cancer cell, and a prong is like a spear where they kill the cancer cells. And that's actually, this is a snapshot from a live video which basically shows how natural killer cells kill cancer cells. So cancer is one component of the overall diseases that occur with aging, and this is part of the immune system dysfunction, and individuals who have an abnormal immune risk profile are likely to get these diseases, where those individuals who don't have this abnormal immune risk profile are less likely to get it. And what do we call that, this abnormal immune risk profile? It's really part of the picture of aging of the immune system, or immune senescence, and it particularly affects the T cells. And the clinical consequences of this decreased immune response with aging are the increased incidence and severity of infections, cancers, autoimmune disorders, chronic inflammatory disorders, and frailty. The same sort of diseases that I showed you in the previous picture, where you saw inflammation, the diseases occurring from it. So therefore, inflammation and decrease or aging of the immune system, or a dysfunction of the immune system, they go hand in hand. And essentially, if we look at the next picture, basically what we see is that we can actually measure our cells, our T cells, and there are particular cells called naive cells, which when we're born, we have many of, and memory cells, which we have few of. But as we age from puberty to adulthood to age to very old, there's a shift that occurs, and there's a typical time point when the shift occurs. Usually it's in the region of 65 to 74 when that occurs, and at that point, that's when the onset of most diseases tend to occur. So we're developing strategies where we can actually measure it before, and to be able to utilize the individual's own stem cells to do that. And this is actually a stem cell transplant for a patient who has a blood cancer. That's effectively what it's doing when we put the stem cells back in, and these patients have long-term survival. So to understand better how the stem cells in a hematopoietic stem cell transplant works, we have to understand, first of all, that cancers occur. And if we look in the triangle on the bottom, you have the origin of tumors, which then grows, and then you have a tumor mass, and at the top, the immune system, which is providing immune surveillance. So as the immune system weakens, indicated by the lightening of the blue to light blue, the tumor grows. So there's an equilibrium point where if we can find that and we can maintain our immune system below that, we are maintaining immune surveillance. And therefore, if we can maintain that, we can then we can achieve our objective of healthy aging. The objective being to basically push our immune system back to maintaining it in a strong way. We do a very sophisticated and comprehensive blood test, where we could measure the immune system, looking at both the innate and the adaptive immune system. We look at markers of aging, in anti-inflammatory and pro-inflammatory cytokines and cancer-killing activity. And putting all of this together, it can reveal deficiencies that would otherwise go undetected in routine blood tests. And this can help the individual to be able to get an understanding of what's occurring with their immune system. And so the question is this: who should be those individuals who measure their immune system? Anyone with a personal family or history of cancer or major illness, health and wellness-minded individuals, persons with high occupational risk, such as firefighters, and of course, you. That's anyone who really is interested in being aware of being proactive in terms of what's happening with their immune system should be looking at that. So what's the purpose of this? We're looking at immune dysfunction, and corrective action could be taken to improve these imbalances. And by being proactive, this can save time, money, energy, stress, and produce good health. And so at this point, I would like to now, before answering questions, I'd like to introduce Catherine. Catherine is one of our coordinators at the Institute here, and she's going to be able to just give you a little bit more information. And following this, then what I will do is I'll be able to take a few questions. So I want to thank you all very much for being a very attentive audience. And now hand you over to Catherine for a few minutes, and then I will come back in again. Thank you so much.
Hi, yes, I'm Catherine, the Education Coordinator with the Stem Cell Institute. And as Dr. Maharaj said, he's just about ready to take a few questions. But before he does that, I would like to invite anyone who doesn't get their question answered now, or who would like more information on any of the topics discussed tonight, to call the Institute on the number on the screen, which is 561-752-5522. Or you can also email us at info@bmscti.org, and you can just ask for myself, Catherine, or Dan. And I would also like to, sorry, one second. Okay, there is also something else I would just like to quickly tell you about, and there it is. Little hiccup there. Dr. Maharaj also offers an online advanced stem cell education program, which is available to anyone seeking further education in the field of stem cells and regenerative medicine, which I think all of us agree is the way of the future. This is one of the most advanced programs for stem cell education and covers the basic sciences and clinical applications for the use of stem cell therapy as we go forward. The faculty includes 50 leading stem cell experts, and some of the specialty courses on offer are stem cell collection and storage, something we do here at the Institute on a regular basis. Stem cells and immunotherapy, musculoskeletal applications, gastroenterology, and endocrinology, excuse me, cardiopulmonary applications, and neurology, ophthalmology. There are a lot of good courses there, a lot of information, and it does go towards your CME hours as well if you are a physician. So if you would like more information on any of the things that I've mentioned, please go to the phone number that I gave before, 561-752-5522, or email us on info@bmscti.org, and we'll be happy to help. So thank you very much for attending tonight, and Dr. Maharaj is now ready to take any questions.
So there's a question from one question that asks, can they be used for MS? I take it that MS, the person is referring to multiple sclerosis. So the answer is that there are many currently there are over 3,000 clinical studies that are ongoing where the use of stem cells are being investigated. And so there are studies looking at using adult stem cells for treating patients with MS. But this is still investigational, and currently to date there are no accepted, proven treatments for it. There's a question on any advice for muscle regeneration after abdominal laparotomy more than 5 years ago. Again, I think that the question there is that muscle contains stem cells which actually can regenerate. I think the question would be, are there any clinical studies which are being done right now? And that could be looked at by just going to clinicaltrials.gov, which would then give you an idea of the specific answer and the specific place that could be doing a question. So that could be answering this question. And there's another question. So, okay to take fat from stomach and put it into cheeks, not okay to take and put into breast. From my understanding, and I'm not an expert on the guidance documents, but from my reading of it, that if it is used as part of the process during the surgery where the surgeon has to use it as a filler, then it's fine. But again, if it's being just used for a cosmetic reason, based upon my reading of that it actually has to be done as part of a study. There's a question, is it possible to learn more about the biomarker panels you use to track the immune system stability? The answer is yes. If you would like to contact us, then we can go into that in more detail with you. The next question is, where can the blood test to verify the immune system status be taken? What is its name? It's a test that we do at the South Florida Bone Marrow Stem Cell Transplant Institute, and you would actually have to come here to have it done here because some of the tests have got to be done in fresh blood. There's another question, any advice for osteoarthritis? Again, the use of stem cells for many physicians are actually using stem cells to treat patients with osteoarthritis, and they also use a product called platelet-rich plasma, which has shown some success. These are things that should be evaluated with your doctor who's actually doing that procedure. There's another question, how about hearing and sight? Can stem cells therapy improve them? This is a subject which was covered extensively in our advanced stem cell online education program. We had top experts who have been working on stem cells for use in macular degeneration as well as retinal diseases, actually showing some of their work. Their work is still early, but I think that further information could be obtained from looking at that. There's a question, could you please comment on the use of stem cells for cardiomyopathy, heart failure, particularly for genetic cardiomyopathy? It seems like using your own stem cells wouldn't work, as you would still be putting the mutation back into your heart. There are many studies ongoing using particular types of stem cells, mesenchymal stem cells from allogeneic donors that have been in clinical study showing promising results. Again, because they're mesenchymal stem cells, because they're not accepted as a standard of care, they are still undergoing clinical studies. And I would urge you to seek those, because they could be a possibility for someone with a cardiomyopathy. There's another question. Do the stored stem cells from cord blood collected at birth remain useful through a child's life into adulthood? The answer is yes. When the stem cells are collected from a baby, there's a certain number of stem cells that's required, and they can be useful up until a certain age because of the numbers of stem cells. However, after that, when the child reaches the age, then it's still possible to use their stem cells, but if they needed it, they would need to get additional stem cells from another source. One of the ways that we are overcoming that is that we are saying that young adults between the ages of 17 and 35, their immune system is at its most powerful, and many of these people would actually donate their stem cells to give it to someone else. Those individuals are prime candidates for also collecting and storing their stem cells for their own use at a later date. So it means that they've got like a twin in the bank. And in many ethnic minorities, where if ever they were to come down with a disease process like a blood cancer, the numbers of donors who they would be able to access is very low in the National Marrow Donor Program. So if they're concerned about a family history of an illness which could be used, where stem cells could be used to treat them, then that's one other option that they have, and that can overcome the issue of not having enough stem cells from the cord blood. So the time is now 6 o'clock, and the plan was that this webinar would be for an hour. So there are many, many questions that I see coming up, and I'm very pleased about the success of the number of people who've been looking at this. As of right now, we have 283 viewers on the, 250 viewers, and so it's, 315 viewers. And so it's very difficult for me. I could be answering questions throughout the evening, but again, I would urge you to contact us, and we would be very happy to be able to answer your questions. Again, thank you so much for being part of the audience and signing up for this. I'd like to thank the members of Life Extension and Mr. Falloon, William Falloon from Life Extension, who requested that this webinar be made available to the members of Life Extension. And we thank you for your support and being with us today. Thank you so much.